I'm also chairman of the medical review board of the local kidney foundation of Utah and Idaho, and my talk is sponsored by them, meaning I'm getting paid thousands of dollars to give this talk. At the ends of your desk, you will see pads that you may want to pick up. These are from the Kidney Foundation, the national organization, and they are related to the National Kidney Disease Education Program. And this helps you folks and us as nephrologists to kind of educate the patients regarding the status of their kidney disease, where things stand, and help them track their kidney disease. So feel free to take as many of these home as you wish and use them in your practice to help you take care of the patients. With that background, I'm going to speak today about fluid and electrolyte emergencies, and I obviously can't discuss every single fluid and electrolyte emergency, but I will be discussing two of the major ones that you may see in your practice. And the first one is that of hypertensive emergencies and urgencies. These are two separate entities, very frequently mixed up with each other, some treated in a more cavalier fashion, some treated more aggressively than necessary, and hopefully by the end of the lecture, you'll be able to tell which patients fit into which category and how to treat these patients. So let's talk about three case scenarios. I'll present these cases, we'll do the talk, and then at the end we'll review these cases again to see where they fit into our scenario. So our first case is a 56-year-old man who presents to the emergency department with headache, found to have the blood pressure that you can see, and papilledema. So the question is this a hypertensive urgency or emergency? Next is an 82-year-old man with a history of hypertension and chronic kidney disease, and presents to your clinic with a blood pressure of 230/130, and he is totally asymptomatic. Is this a hypertensive emergency or urgency? And I'm fighting a cold, so please pardon me as I go along here. And the third is a 76-year-old woman who is brought to the emergency department because of altered mental status. You see what her blood pressure is. She has no focal neurological findings. Is this an emergency or an urgency? So these are the definitions. And you'll see that malignant hypertension is really not mentioned here. And that term is starting to go by the wayside, and the hypertension gurus are really not using that terminology anymore. But a hypertensive emergency is also called a hypertensive crisis, and these patients have severe hypertension with acute impairment of an organ system. It can be the central nervous system, the cardiovascular system, the kidneys, and there's no absolute level of blood pressure that qualifies you for that. So if you have a pediatric patient with a blood pressure of 150 or 160, you can certainly have malignant hypertension in such a patient, or a pregnant woman in her third trimester can also qualify for malignant hypertension if she has end organ damage, in spite of what the numbers tell you. Hypertensive urgency is the blood pressure with potential risk, but hasn't yet caused end organ damage. These patients do not require emergency treatment. They don't require intravenous drugs. They can be treated at a more leisurely pace, and they have no end organ damage, but they are at risk for developing complications down the road. And then accelerated hypertension is that of patients with recent increased blood pressure over their baseline associated with possible target organ damage. This is usually seen as damage seen on fundoscopic examination, where they may have flame hemorrhages, exudates, but without papilledema. If a patient has papilledema, they're in a hypertensive emergency. So, as a background, there are probably at least 60 or 70 million hypertensives in the United States. 70% have mild hypertension, 20% moderate, and 10% have severe hypertension. And in their given lifetime, about 1 or 2% of patients will develop a hypertensive emergency with end organ damage at some point in their career. Their morbidity and mortality depends on the end organ damage. And, the degree to which the blood pressure is subsequently controlled. So the morbidity and mortality depends on their blood pressure, end organ damage, and how aggressively the blood pressure is treated. In untreated patients, their mortality is greater than 90% in 1 year. People who present with a hypertensive emergency have a 74% 5-year prognosis, especially if treated. African Americans have a much higher incidence of developing malignant hypertension. Again, I'm using the old term, a hypertensive emergency. And males are at much greater risk than females. And it happens most frequently in middle-aged persons. Okay, what's the main cause? This is a rhetorical question, but the main cause is number 5. Oh, boy. The main cause is number 5, non-adherence to hypertensive regimen. So most of the patients who come in with a hypertensive emergency have been previously diagnosed with hypertension and have not been compliant with their medications or have stopped their medications suddenly. All these other causes are much less frequent, and although we look for these problems in these patients, the most common causes are those with non-adherence to their regimen. So what happens? I'll get this right yet. Patients with hypertension, for some reason, develop a sudden increase in systemic vascular resistance. This may be increased sympathetic tone. They may have increased production of renin-angiotensin, but they develop mechanical stress of the blood vessels with endothelial injury, increased permeability of the blood vessels, activation of coagulation factors, and fibrin deposition. They get ischemia of their downstream organs, further activation of the renin-angiotensin system, pro-inflammatory cytokines, and it's a vicious circle, and these patients can, again, develop malignant or hypertensive emergencies. And these are common associations seen in patients with hypertensive emergencies. The majority of them will have a previous history of hypertension. Very frequently, they will have lack of a primary care provider, so they haven't had good medical care. They've been non-adherent to their prescribed regimen, and many of them have a history of illicit drug use. The etiology is multifactorial, but the highlights show you the major causes. And again, we talk about patients who have essential hypertension with inadequate blood pressure control or non-compliance with their medications. The other important factor is withdrawal syndromes. There are 2 major classes of drugs that can cause malignant or hypertensive emergencies if they're withdrawn, and these are clonidine and beta blockers with activation of the sympathetic nervous system. The others are much less common, and drug abuse is one of them. There are also a number of medications that may precipitate hypertensive emergencies. I'm sure you're pretty familiar with most of these: oral contraceptives, MAO inhibitors, corticosteroids, nonsteroidal anti-inflammatory drugs, and so forth. So, patient presents with a hypertensive emergency. They can present with dysfunction of the central nervous system, heart, or the kidneys. The central nervous system is affected as the elevated blood pressure overwhelms autoregulation. Autoregulation means that as the blood pressure goes up within the normal range, the cerebral circulation remains at a fairly constant level, so that our cerebral circulation protects us from the high blood pressure as the blood pressure goes up. At some point, when the blood pressure rises above a certain level, the autoregulation is lost and the cerebral blood flow goes up, cerebral blood pressure goes up, and that's when we develop the encephalopathy. In patients with chronic hypertension, this curve is moved to the right. In some patients, they lose autoregulation, and as the blood pressure goes up, the cerebral blood pressure goes up, and these patients will develop malignant hypertension with central nervous system complications. These patients can get vasoconstriction, and when they lose autoregulation, the vasoconstriction can't make up for the elevated blood pressure. The elevated blood pressure is transmitted to the brain, and they develop their central nervous system dysfunction. Again, we talked in the previous slides about the fibrinoid necrosis, loss of autoregulation, and this is how hypertensive encephalopathy develops. In the heart is affected in a number of ways, mostly by increased cardiac workload, and these patients can present with heart failure. This may be accompanied by either pulmonary edema, myocardial ischemia, or infarction. And in the kidneys, the same autoregulatory mechanism that works in the brain works in the kidneys. When the blood pressure overwhelms the autoregulatory mechanism, you again get ischemia of the kidneys, again with the fibrinoid necrosis and the development of acute renal failure, hematuria, and red cells, and occasionally proteinuria. So when you're working up the patient, history is obviously important, and a couple of points in the history. You want to make sure that you know what medications they've been on, especially whether they've been taking their antihypertensive drugs, and whether they've been compliant with their medications, and whether they've been taking illicit drugs as well. You want to know how long they've been hypertensive. With women, menstrual cycle is important to make certain they're not pregnant, that they're not having birth control-induced problems. And you wish to obviously obtain other important historical issues. And the complications are quite important in determining the severity of the hypertensive emergency. Are they having central nervous system problems? Headaches are frequent. They may have blurred vision due to eye disease from the hypertension. They can have weakness, fatigue, mental status changes, and you obviously want to do a fairly good examination of the cardiovascular system, make certain that they're not in pulmonary edema, make certain that they're not having heart failure, make certain that they're not having a myocardial infarction. So what is the most common complaint by patients with hypertensive emergencies? I think gross hematuria is probably not very frequent. Chest pain is probably one of the more frequent complaints that these patients will present with. Headache is not very frequent. Epistaxis, very infrequent. Dyspnea and neurological deficits. So the patients who present with hypertensive emergencies, their most frequent presenting complaints are related to cardiovascular or neurological problems. In terms of your physical examination, again, your three main organ systems are the ones you wish to concentrate on in terms of a good neurological examination to make certain that they're not having focal neurological abnormalities. You obviously wish to examine their fundi carefully to make certain that they do not have papilledema, and then do a good cardiovascular examination looking for signs of volume overload or signs of aortic dissection. And then finally, you want to check for abdominal masses and bruits, again, to look for the presence of an abdominal aneurysm. The lab workup, I won't go into much detail, but obviously the chemistry profile, doing toxicologic assessment to make certain that these patients are not using illicit drugs, and in some cases, CAT scans to rule out intracerebral processes, as well as CAT scans to rule out dissections, and obviously cardiac workup as well. So the treatment is quite important in terms of how you approach these patients. Our tendency is to try to bring the blood pressure down rapidly and to a, quote, normal level. But this is not in the patient's best interest. The only situation in which a patient's blood pressure needs to be brought down rapidly and to a near normal level is if they have an aortic dissection or a ruptured aneurysm. Otherwise, a more leisurely course is obviously much more important. So you wish to weigh the benefits of decreasing the blood pressure against the risks of decreasing end organ perfusion. If we bring the blood pressure down too rapidly, the autoregulation that had been set up and that has maybe been foiled cannot adjust to the lower blood pressure. And if you bring the blood pressure down too low, then you run the risk of hypoperfusion of vital organs. So in a few minutes, we'll get into target lowering of blood pressures. But you need to evaluate the patients appropriately, correctly classify the hypertension, make sure that the patient is really having a hypertensive emergency rather than an urgency. In the clinic and in the emergency department, our reflex is to bring the blood pressure down. If a patient presents with a blood pressure of 180 over 190 and they're asymptomatic, we can't let them go home with that level of blood pressure. And if they're asymptomatic, trying to bring it down in the emergency department with intravenous drugs is really not in those patients' best interests. So that determine the classification of the hypertension and then decide to treat them aggressively or not aggressively, depending on whether they're in an emergency or urgency. Treat the patient and not the number. We're called frequently by nurses on the floor. The patient's blood pressure is so-and-so, and they wish something done. It's a number. It's easily dealt with. You can give them a medicine. It'll bring it down. Is that doing the patients any good? The answer is no, unless they're in a hypertensive emergency. A hypertensive urgency is a much more leisurely disease in terms of treatment and needs much less aggressive, urgent emergency treatment. I think that's the one takeaway lesson from all this. So, place the patient who is not in distress in a quiet room and reevaluate after an initial interview. Don't jump in with intravenous drugs, oral nifedipine, or some other major action without first letting the patient settle down, see if the blood pressure comes down. In one study, 27% of patients whose initial blood pressure was greater than 130, diastolic, had their blood pressure fall without any specific treatment other than relaxation. Consider the context of the elevated blood pressure. Are they having severe pain? Are they in severe mental distress? Do they need the calming atmosphere to bring the blood pressure down? And this gives you a chance to screen for end organ damage. And if they have end organ damage, specifically papilledema, evidence of heart failure, neurological dysfunction, then you need to admit those patients to the intensive care unit for aggressive treatment. The suggested medications depend on which end organ systems are damaged, and I'll get into those in a few minutes. If the patient has no evidence of end organ damage, you may actually be able to discharge them from the emergency department and treat them as an outpatient. So again, hypertensive urgency does not necessarily require admission to the hospital, does not require intravenous drugs, and can be treated in a more leisurely fashion. And oral nifedipine, hopefully, is out of all of our armamentariums. 10, 15 years ago, that was frequent. The patient came into the emergency department, had a blood pressure of 190. They were given a sublingual nifedipine to bring the blood pressure down. Those patients developed hypotension. We got into trouble with those patients, and that practice has hopefully been abandoned. And for most patients, the greatest risk of treating an emergency is the risk of accompanying hypotension. So you want to treat these patients. The majority of them, if not all, will require intravenous drugs in the intensive care unit, but you need to make certain that you're treating them with short-term, short-acting drugs that are easily titratable and can be discontinued if the patient becomes hypotensive or symptomatic from low blood pressure. So the American College of Emergency Physicians has given these guidelines. Initiating treatment for asymptomatic hypertension in the emergency department is not necessary when patients have follow-up. So you don't need to give them a prescription for medication and say, here, take this and come back in 2 months. You make sure that they have follow-up, and you don't necessarily need to place them on treatment right away. And the second point is that rapidly lowering the blood pressure in asymptomatic patients in the emergency department is unnecessary and may actually be harmful to the patients. And finally, when you're treating these asymptomatic patients, lower the blood pressure gradually. You cannot target a normal blood pressure in the 2 or 3 hours they're in the emergency room by the time they leave. So again, not over-treating these patients, not being overly aggressive is the most important point here. In hypertensive urgencies, the treatment is oral medications, fast follow-up, and you start with short-acting drugs, but not oral or sublingual nifedipine. Now, once you have made the diagnosis of a hypertensive emergency, your target should be a decrease of about 25% of the mean arterial pressure. The category of dissecting aneurysm is separate, obviously, but this is for the other patients with hypertensive emergencies. And there are basically 2 main classes of drugs, vasodilators and adrenergic agents. And these should all be used in the emergency department or in the intensive care unit. These patients should be placed in the intensive care unit and given these intravenous drugs to bring their blood pressure down. Nitroprusside is an old favorite, and you have the dosage here. And it's instantaneous, and it's a very powerful vasodilator, brings the blood pressure down. The major side effect is that nitroprusside has cyanide, and these patients can develop cyanide toxicity. And this is especially true in patients who have any degree of kidney insufficiency. So that patients who have kidney disease, we need to be very careful with nitroprusside, especially after 24 hours. Nitroglycerin, you can see the dosage. Again, it's an instantaneous drug, and the major complications are headache and flushing, and this drug is essentially reserved for patients with ischemic heart disease. Nicardipine is an intravenous calcium channel blocker. There's also a second intravenous calcium channel blocker called clevidipine, which is also available. The dosage here is 5 to 15 milligrams per hour, and it's instantaneous. And the patient's major side effects are tachycardia or flushing. Hydralazine should really not be used in hypertensive emergencies. Hydralazine has an incomplete or unpredictable mechanism of action and unpredictable degree of action, and it's a little bit longer acting. It has a half-life that's a little bit longer, and if you develop hypotension with hydralazine, then reversing it is a little bit difficult. So you wish to avoid it, especially in aortic dissection, because these patients can develop a reflex tachycardia. Enalaprillat is an intravenous form of an angiotensin-converting enzyme inhibitor and really should only be reserved for patients who have heart failure. And it's a fairly rapidly acting drug. And phenoldiprem, which is a rapidly acting drug as well and has a very short half-life, also has some side effects of flushing, headaches, and tachycardia. These are all intravenous drugs. The ones that are given by continuous infusion have a short half-life, they have short onset of action, and their effect can be reversed with discontinuation of the drug. On the other hand are the adrenergic inhibitors, labetalol, esmolol, and phentolamine. Phentolamine is really reserved for patients who you suspect have pheochromocytoma, patients with hyperdynamic kinds of hypertensive emergencies, labetalol is an excellent drug. It's a fairly rapidly acting drug in terms of less than 5 to 10 minutes. It can be titrated as an intravenous infusion, and its major side effect is that it can cause heart block. Oral drugs, again, are not used in hypertensive emergencies, but in a hypertensive urgency, you can either use clonidine, which is a fairly rapidly active drug within 30 to 60 minutes, has a long half-life, and you may send patients home on clonidine while they're waiting to make an appointment with their primary care provider to get a better workup and treatment of their hypertension. Again, labetalol has the advantage of being both intravenous and oral, and may be used orally in these patients as well. Now, in terms of specific disease processes, in patients with hypertensive encephalopathy, the goal is to reduce the mean arterial blood pressure by about 25% initially, within the first hour or two. Nitroprusside may result in an increased intracranial pressure, so that should probably be avoided in patients with hypertensive encephalopathy, and currently the drugs of choice are either labetalol or phenoldiprem. If a patient has an intracerebral hemorrhage, as the intracerebral pressure rises, the mean arterial pressure must rise for perfusion, and so in intracerebral hemorrhage, the patients are less likely to tolerate aggressive lowering of blood pressure, and so you need to be a little bit less aggressive with these patients, and labetalol and esmolol, which will decrease intracerebral pressure, are the drugs of choice. In spontaneous and subarachnoid hemorrhage, nidotropine has been used, but this drug can cause chemical irritation and is not recommended routinely due to frequent incidents of hypotension, and these patients, labetalol and esmolol, again, are the agents of choice. Now, acute ischemic stroke is a controversial issue, and the level of blood pressure lowering is not clear. There's some data that lowering the blood pressure to normotensive levels is actually bad for these patients and may actually worsen the stroke by decreasing the perfusion of the surrounding area around the stroke. So that in a study, in a Cochrane review of 65 randomized trials, that there's insufficient data to evaluate blood pressure lowering post-stroke. So the current guidelines are to bring the blood pressure down below 220 and below 120 unless end organ damage is due to the blood pressure. So the whole issue of how aggressive to be with acute stroke patients is unclear. Probably bringing them down below 200 millimeters of systolic is reasonable, but bringing them down below 150 or 160 systolic may result in worsening of the stroke. The only proviso here is that if the patient is going to be receiving thrombolytic therapy, then a lower blood pressure may be necessary to prevent changing the thrombotic stroke into a hemorrhagic stroke. In aortic dissection, bringing the blood pressure down with a beta blocker is really the most important treatment, and in these patients, labetalol or nitroprusside plus a beta blocker is really the treatment of choice in these patients. Myocardial infarction can be treated with nitroglycerin, beta blockers, and ACE inhibitors. In patients with acute left ventricular failure, these patients will have pulmonary edema and systolic and diastolic dysfunction. Nitroglycerin, enalaprilate, and diuretics are really the drugs of choice in these patients. The complications of hypertensive emergencies. These patients may come in with these problems, and abrupt lowering of the blood pressure may actually worsen the problems, again, making the treatment of the hypertensive emergency problematic in terms of being too aggressive, and again, a 25% decrease in the blood pressure is your target. The median survival is 144 months who present with all patients who present to the emergency department with an emergency. And again, as I mentioned before, their 5-year survival is 74%. Interestingly, there have actually been very few randomized published trials on the outcomes of treatment for hypertensive emergencies. In hypertensive emergencies, there's only one randomized trial that's been published. In hypertensive urgencies, there are only 10 randomized trials. And the conclusions are that these patients are heterogeneous, the small sample sizes, and the interventions and outcomes are really unclear. So, this is an old term, malignant hypertension. The 56-year-old male who presents to the emergency department with headache, elevated blood pressure, and papilledema, this is a hypertensive emergency. The 82-year-old male who has renal insufficiency but is otherwise asymptomatic, this is not a hypertensive emergency. This patient has accelerated hypertension and needs aggressive treatment but not emergency treatment. And the patient who is brought to the emergency department with altered mental status, with no focal neurological findings, but with papilledema, that's a hypertensive emergency. So hopefully we've developed an idea of which patients are fitting into the category of emergencies, which patients are fitting into the category of urgencies, how aggressive to be with these patients in terms of the workup, and how aggressive to be in terms of the treatment. Finally, the principles of therapy are to lower the blood pressure over hours. This is a goal blood pressure, 160/90, but again, you have to take the patient's clinical situation into account. Too rapid a lowering, again, may cause dire consequences, specifically consequences related to hypotension and hypoperfusion of vital organs. It may take several days to get reasonable levels of blood pressure, and it really should take several days. To bring the patient's blood pressure down to normal in a hypertensive emergency is really unwarranted, other than in patients with dissection. And finally, avoid medications that cannot be controlled, specifically sublingual nifedipine. The other half of my talk will revolve around hyperkalemia. And we're all pretty familiar with hyperkalemia. Just about most foods that we eat do have potassium in them. About 10% is excreted through the GI tract, but about 90% through the kidneys. The most important site for getting rid of potassium is the distal nephron, including the distal convoluted tubule, the connecting tubule, and the cortical collecting tubule of the kidney. Now, increased potassium excretion is manifested by aldosterone, high sodium delivery to the distal tubule. So if you're delivering high amounts of sodium to the distal tubule, if the urine flow is high, you'll be excreting more potassium. Obviously, patients with high serum potassium levels will excrete more potassium. And patients who have increased delivery of negatively charged ions to the distal tubule, such as bicarbonate, they'll exchange more potassium and get rid of more potassium. So in patients who are excreting a lot of bicarbonate, you can also expect them to develop hypokalemia. Excretion is decreased by these factors. If for some reason you have absence of aldosterone, if you're volume depleted, or for some other reason you're delivering less sodium to the distal tubule, if your urine flow is low, or if you have chronic kidney disease. Normal potassium level, 3.5 to 5. Our daily requirement is about 1 to 1.5 millimole per kilogram. And you can see the different foods that have high potassium content. And let me recommend that if you do have patients with hyperkalemia, a dietitian is a very, very helpful person in helping you deal with these patients. Hyperkalemia is defined as serum potassium greater than 5.5. That doesn't mean it's dangerous. It just means it's abnormal and may require attention. we need to be careful that we don't label the patients with hyperkalemia and look for pseudo-hyperkalemia. This is a term that applies to a clinical situation where in vitro lysis of the cells leads to loss of potassium from the cells and a falsely high potassium level in the tube that's being used to measure the potassium. This is seen in patients where the blood draw has the tourniquet too tight, or the blood is left sitting in the tube for too long a period of time, where the cells die and release potassium. Or it can also be seen in patients who have severe leukocytosis or severe thrombocytosis. So if you have a patient with hyperkalemia, just keep this in mind, especially if their kidney function is normal. Now, the causes of potassium of hyperkalemia can be due to excessive intake, decreased excretion, or the shift of potassium from the intracellular to the extracellular space. The concentration of potassium in the cells is about 130, 140 milliequivalents per liter. In the serum, it's 5 milliequivalents per liter. So if we have a shift of potassium from the cells out into the extracellular space, this may cause hyperkalemia as well. Excessive intake is fairly uncommon, and the mechanism for shifting potassium intracellularly, if the patient ingests a lot of potassium, makes it very difficult for these patients to develop hyperkalemia unless they have abnormal kidney function. So most often, hyperkalemia due to excessive intake is caused in a patient with impaired mechanisms for either the intracellular shift of potassium or inability to excrete potassium. So in the big picture, excessive intake is a very uncommon cause of hyperkalemia unless some other factors are operating. The most common causes of hyperkalemia are decreased excretion. This is usually seen in patients with chronic kidney disease, in patients with diabetes, sickle cell, and some medications that they may be prescribed. And you can see here a number of drugs that may be associated with hyperkalemia. Drugs that downregulate aldosterone. Most of these are the blockers of the renin-angiotensin system, but the non-steroidal anti-inflammatory drugs may also interfere with the action of aldosterone in the distal tubule and decrease potassium excretion. We can also have this problem seen in aldosterone receptor antagonism, such as with spironolactone or eplerenone. You can have collecting tubule sodium channel blockade by these drugs, and triamterene and amiloride are probably frequent drugs that can cause this. Blockade of the distal sodium-potassium ATPase by these two drugs that are used for kidney transplants and for immunosuppression, and by changes in intracellular potassium balance. Now again, we mentioned that increased ingestion is uncommon, and changes of intracellular to extracellular potassium shift are uncommon as well. So the most common causes of hyperkalemia are patients with chronic kidney disease. In these patients, the shift from intracellular to extracellular space can exacerbate hyperkalemia produced by renal insufficiency, but really the shift across cell membranes is pretty uncommon. It can be the major cause of hyperkalemia in hyperosmolality, where the hyperosmolality of the extracellular space draws fluid out of the cells into the extracellular space. In patients with rhabdomyolysis or tumor lysis or succinylcholine administration, where you get cell paralysis or cell death, and in patients with insulin deficiency. Insulin is very important in moving potassium into the cells, and in patients who have insulin deficiency, they can develop hyperkalemia, especially if they have abnormal kidney function. So, the causes of excessive intake are either IV or oral potassium supplementation, salt substitute, and hopefully we all know that salt substitute is basically potassium chloride, and this should not be prescribed to patients who should be on a potassium-restricted diet, and blood transfusions. Decreased renal excretion You can see the many causes here, including patients with chronic kidney disease, treatment with nonsteroidal anti-inflammatory drugs, ACE inhibitors, and potassium-sparing diuretics. Multiple myeloma may also affect the ability of the kidneys to get rid of potassium. Are there any symptoms of hyperkalemia? In the vast majority of patients, no. These patients may have muscle weakness and fatigue, and in severe cases may develop muscle paralysis. They may develop shortness of breath, and they may develop palpitations if they develop cardiac arrhythmias. And in physical examination, there's really no hallmark physical findings related to hyperkalemia other than possibly tachypnea due to respiratory muscle weakness. The EKG is really the major test to help determine whether the hyperkalemia is a life-threatening problem. The initial finding is a T wave that's peaked or tented. Next is ST depression and loss of the P wave. Finally, you get QRS widening, and at the very end, you get a sine wave with loss of the QRS. So this is a patient with fairly early hyperkalemia. You can see that there's a loss of P waves, and there's a peaked T wave. This is a pre-death electrocardiogram of a patient with hyperkalemia. You can see they're developing the sine wave kind of electrocardiographic findings, and this is obviously a medical emergency. 3 phases of treatment for hyperkalemia. Number 1, stabilize the myocardial membrane. Number 2, drive the potassium into the cells. And number 3, remove potassium from the body. Number 1 is stabilize the myocardial membrane. When the potassium goes up, that affects our cardiac conduction system, and you saw the electrocardiographic findings. The treatment here is to stabilize the cardiac membrane while you're buying time to take your other measures. And the main treatment here is calcium. Calcium antagonizes the cellular effects of hyperkalemia. Vast majority of time, calcium gluconate is the drug of choice. This can be given intravenously, either in a peripheral vein or in a central vein. Calcium chloride can also be used, but this should be given in a central vein because of the likelihood of it causing local sclerosis and gangrene. The other emergency treatment is that of albuterol. This will drive potassium into the intracellular space. Now, for a patient with asthma or lung disease, the usual dose is 0.5 cc's. In patients with hyperkalemia, they receive a much higher dose of albuterol inhalation, and this will drive the potassium into the cells and bring down the potassium. This does nothing for total body potassium, but this buys you time to bring down the potassium level while you're undertaking other measures. The effects are fairly rapid, and the only negative to this is the high dose of agonist that you're giving the patient. Insulin and glucose drives potassium intracellularly. Again, you give glucose with insulin. Insulin is a main mover of potassium into the cells along with glucose, and you can bring the potassium down on this basis. The effect is fairly rapid, and the duration may be of several hours duration. And then finally, driving potassium into the cells with sodium bicarbonate, it causes an alkalosis. You drive hydrogen ion out of the cell and drive potassium into the cell. Removal of potassium from the body, it really should be the major effort to bring down the potassium level. Loop diuretics lead to loss of potassium in the urine. This is assuming that the patient's kidneys are working. And you need renal function, and you need adequate volume to get the filtrate to the loop of Henle. As I said previously, you need sodium delivery to the distal nephron to get rid of potassium, so that if the patient's kidneys aren't working, this will probably not be of much benefit. Sodium polystyrene sulfonate, or K-oxalate, exchanges sodium from potassium in the gastrointestinal tract, and this is very commonly used for patients with hyperkalemia. Both can be given orally and rectally. However, there's a major adverse reaction to this in terms of intestinal necrosis and gangrene, especially when it's used with sorbitol. And this was an article of ileocolic perforation secondary to K-oxalate, and this has been reproduced a number of times, so that the use of K-oxalate with sorbitol, especially in the enema, is strongly discouraged at this time. Whoops. So the first step is determine how life-threatening the hyperkalemia is by performing an electrocardiogram. If cardiac toxicity is noted, give IV calcium to relieve the cardiac toxicity. The effect occurs in minutes and can last for at least an hour. You can identify and remove the sources of potassium intake, change the diet to a low potassium diet, discontinue the medications that have caused the hyperkalemia. And finally, if none of the above measures are successful, then these patients can receive dialysis to remove potassium. Let me say that peritoneal dialysis is not nearly as effective as hemodialysis in terms of removing potassium. And if you have a patient who has life-threatening hyperkalemia, if you've stabilized them for the short term and you have no other way to bring down the potassium, hemodialysis is really the treatment of choice in these patients. And I'll stop there now, and if you have questions, please go to the microphones. For hypertensive urgency, there is no number for either hypertensive urgency or emergency. I think you have to look at the number and look at the patient. If a patient comes in with a blood pressure that's over 180 or 190, that needs attention. Is that an urgency? No, especially if they don't have any end organ damage. But that does require workup and treatment in a fairly rapid fashion.
It seems like just asymptomatic hypertension and hypertensive urgency are pretty similar.
It's a gray zone between hypertensive urgency and asymptomatic. Hypertensive urgency, you can have hemorrhages, you can have exudates. As long as they don't have papilledema or any of the other end organ damage, then you may classify those as hypertensive urgency and get them on treatment fairly rapidly.
And does the hospital have the albuterol, the 5 cc solution?
Yes.
I've never prescribed it. Okay.
Oh, go ahead.
I have a question about hypertensive urgency versus emergency also. I have an 80-year-old patient who has anxiety, very labile blood pressures, and so she comes in for a normal office follow-up and feeling fine, except she says she has numbness on the side of her face for 3 days, and her blood pressure is 180 over 105, maybe up to 110. And like I said, it's been going on 3 days. On exam, she does have numbness on one side of her face. Is that an urgency or an emergency?
Oh, boy. If it's a 3-day process with numbness on the left side, that's at least an urgency. I think that as I was telling her, that's a gray line between urgency and emergency. That patient needs to have their blood pressure brought down, probably under controlled circumstances. And you probably should hospitalize somebody like that and treat them fairly urgently in the hospital.
Yeah.
Whether you put them on an intravenous drip, if you can't document any other central nervous system abnormalities, I think that's really not necessary.
Okay. Thanks.
Yes?
I just have a question about hyperkalemia. Sometimes we do labs in the office, and then we get a critical lab value later that night of hyperkalemia, so we don't have access to an EKG necessarily at that moment. Is there a certain number? I mean, if the patient's feeling fine, should we all send them into the ER to get an EKG, or is there a certain number we should use?
If it's below 6, I wouldn't bother.
Okay.
If it's above 6, I think medical legally, you're pretty much obliged to have them come in and at least get an electrocardiogram.
All right, thanks.
Okay, my question is, in the office, I have not had a good response with clonidine at all. Nifedipine used to work great, but I don't use it, obviously. My question is, can you use sublingual nitroglycerin, or can you use any other type of beta blockers rather than labetalol?
Probably labetalol has the fastest onset of action,
Okay.
and if you're treating an urgency, you probably need to have them on 2 or 3 drugs right off the bat.
Okay.
So that if somebody comes into your office with blood pressure greater than 160 or 170, the current studies show you need to start them on 2 drugs right off the bat anyway.
Okay.
So they should at least be on a diuretic and another drug.
I mean, these are the patients that are on 5 medicines already and have good readings at home and come in and have, 180 over 110 or something like that. And that's, I say, well.
Do those patients have white coat hypertension? If their blood pressure at home is normal, then I wouldn't do anything other than have them follow up.
All right.
You're treating a number again rather than the patient's disease.
This is the situation that kind of brought this question on. I had a lady that came in with a 90-year-old woman who came in with like a 240 over 140, and I told her, well, I'm going to take you to the hospital, and she jumped up and down and said, no, you're not, and she screamed and carried on. I said, calm down, I won't force you. Well, she point blank refused, and so I felt I was obligated to do something to help her. She was not symptomatic at all, 90 years old, not symptomatic at all. So I tried everything in my little cupboard, and I got it down slightly, and then did a renal artery scan, and sure enough, she had renal artery stenosis. But I felt so uncomfortable until that next day when I could get that renal artery stenosis. So I had to use everything, and I did use nitro, and it did help. So I know it was a scary situation, but that's why I asked. I tried all the other stuff. It didn't work.
Well, if the patient doesn't want treatment, that's a different story.
Yeah. Yeah, 90 years old. I mean, if you made it that far, I guess. She has that choice.
Yeah.
A common occurrence at our clinic, it seems like, is the asymptomatic patient with a systolic blood pressure over 200. What I'm wondering is, can we say they don't have end organ damage just based on a clinical exam, or do we need labs, meaning ER evaluation, to get immediate labs to say that, in order to send them home and just start some oral meds?
You can tell if they have central nervous system dysfunction.
Right.
You can look at their fundi.
Mm-hmm.
If those are normal, you might at the very least get a urinalysis.
Yeah.
And on exam, you can tell if they're in heart failure.
Mm-hmm.
So if all of those really are normal or negative, you probably need to get a little bit more aggressive in terms of the treatment in your office.
Right.
But it's okay to send them home.
You don't necessarily need those immediate labs.
Right.
Okay, great.
Not too long ago, I had a person right prior to the procedure had her blood pressure checked, and it was like 190s to 210s over 110s to 130s, and it was a specialist office, so we're trying to send the patient immediately to a primary care to get this worked up, and she kept insisting that I have white coat hypertension. I'm very nervous about this procedure, and my question is just at what point is it no longer possible that this is white coat hypertension making your blood pressure this high?
If the blood pressure is repeatedly high, number one.
Mm-hmm.
And if you have a way to have them check their blood pressure at home, have them come in and have your nurse check the blood pressure when you're not around. But if it's repeatedly that high, you really are obliged to put those people on treatment.
So you can get hypertensive urgency ranges with white coat hypertension?
You can.
Okay.
We oftentimes see a patient who comes in with admitted high alcohol intake on a regular basis with very high blood pressures and don't seem to show any other end organ damage at that point. How does that enter into our decision making for these patients?
Well, you're going to try to get them off alcohol, obviously. If you're not successful, that's a real tough problem. You probably need to treat those patients. The other unrecognized problem is sleep apnea, and I think there's a high incidence of difficult to control hypertension associated with sleep apnea. So if you're not successful in getting the patients under control, you need to test them for sleep apnea, especially if they have the body image of it. In terms of alcohol, alcoholics are at higher likelihood of having hypertension. So you need to get them off alcohol. You can't do it, then you just need to put them on drug therapy. I don't know if does that answer your question.
It's oftentimes refractory. You'll see people struggle with it to get them down far enough, and it really is hard in the presence of that much alcohol.
Absolutely. Any other questions? Yes. Nope, use the microphone.
My question is, do you treat pseudo-hyperkalemia?
No. Pseudohyperkalemia is an artifact of the blood draw itself, meaning that the potassium is high in the tube of blood, but not in the patient. You treat the...
This is pseudo-hyperkalemia from thrombocytosis.
Well, you treat the thrombocytosis because the patient's blood potassium level is not high. It's just high because all the platelets died in the cell and released potassium. So you don't treat that. Last question.
Do you know what the mechanism is by which alcohol induces hypertension?
It's not completely clear. It's probably a sympathetic problem. And drugs that treat the sympathetic system, such as beta blockers or clonidine, are probably your best drugs of choice in that situation. All right. Thank you very much. Our next speaker.